Hey, good morning. It's Zeki Hamid. It's Monday, and this is Seattle Now. In Washington state, the involuntary commitment system doesn't work. That's something critics who want to make the process easier and critics who want to see it used less can agree on. So far, reforms from Olympia have been underutilized, if they're done anything at all. We'll learn more about our involuntary commitment system, flaws and all, with Seattle Times reporter Jayati Ramakrishnan in a minute. But first, let's get you caught up. Local disaster preparedness officials say they're being barred from communicating with their federal counterparts at FEMA. FEMA told local agencies they'll no longer communicate with each other through the usual channels. That's according to a spokesperson for U.S. Senator Patty Murray. Murray's office said the change appears to be part of President Donald Trump's push to centralize control over FEMA's operations. Meanwhile, King County Council members are calling on FEMA to reconsider their denial of emergency funding for last year's bomb cyclone. Washington Attorney General Nick Brown is taking a part in a community town hall tonight focused on protecting democracy and the rule of law. He'll be joined by attorneys general from Oregon and California. Tonight's event is at Town Hall Seattle, beginning at 6 o'clock. It's free, but you have to RSVP in advance. And if you can't make it in person, it'll be streaming live. And local businesses can take part in a free legal training tomorrow, that's Tuesday, about how to prepare for workplace immigration raids. It'll cover legal basics and what records to keep, and also what to do if federal agents visit your business. The free online training is provided by the nonprofit Communities Rise and funded by the City of Seattle. It begins at noon tomorrow. Check back for more headlines on tonight's episode of Seattle Now. Involuntary commitment, or the legal process of admitting someone for treatment against their will, was once used liberally. Being gay or being a woman seeking divorce was enough to get you sent to a distant psychiatric hospital for years. There are safeguards now in Washington state that protect people's rights. Many of these were introduced as rights for the mentally ill and public safety protections under the Involuntary Treatment Act back in 1973. Today, some involved in the system, or close to people they see as danger to themselves or others, see these safeguards as obstacles to helping vulnerable people. Advocates seeking easier access to involuntary commitment and advocates hoping for alternatives to it agree on one thing: the system has lots of room for improvement. Jayati Ramakrishnan is here. She's a Seattle Times mental health reporter. She's here with some new reporting that looks into Washington's involuntary commitment system and efforts to reform it. Thanks for coming in, Jayati.
Thanks for having me.
So how does a person deemed a danger to themselves or others or gravely disabled get into involuntary commitment in Washington state?
So in Washington, the system is a little unique. There is only one type of professional that can make that initial determination, and it's called a designated crisis responder.
Okay.
So these are mental health professionals who will come in if they're called by a family member, a medical professional, or somebody who has a person that they believe needs more serious mental health treatment. So these designated crisis responders, or DCRs as they're called, will come and assess the person. And if they determine that the person is meeting that criteria, that person can then be detained initially for up to 5 days, typically in what's called an evaluation and treatment center, or maybe in a medical hospital, wherever there is space, basically. That period of 5 days is for initial evaluation and assessment of whether that person needs further commitment.
Okay. So those DCRs, what are their qualifications? Are they mental health professionals?
They are mental health professionals. And so sometimes in various parts of the state, they may overlap. They may have other overlapping qualifications like a mobile crisis responder. But typically they are trained to provide this initial assessment for a person. There are some challenges with it. They are coming in and making this decision based on kind of a snapshot of this person's mental health or condition. So they may get called and may arrive within a few hours, and they'll only see that person in that moment.
Oh, wow.
And so that could go both ways. It could mean that they see the person at their most escalated and they may decide that person needs commitment, or they may arrive and that person has stabilized and they may decide, okay, this person doesn't need commitment. And those who spend more time with the person, whether it's family members, friends, medical professionals who see them more regularly, may have a different view of the person because they're seeing them more in kind of have a broader scope of what that person is like.
So that's one of the challenges that you're mentioning here. I want to know, aside from this, what about the system that isn't working for people that it's supposed to help?
I would say first and foremost, people who need treatment often can't get into the system because of various reasons, including the one I just described with DCRs, having kind of a limited window to make that decision. There are a lot of issues with having enough space.
Like hospital beds?
Yeah, hospital beds or behavioral health facilities. And even as the state has tried to build out that system, they've run into problems with that. I've done some reporting on the UW behavioral health facility that's supposed to take civil commitment patients, but they've, for several reasons, not been able to accept them at the rate that they thought they would. And so, yeah, there's various issues with it. And I would say that the other big concern is that those who do go through the system often don't get that kind of long-term resolution. Oftentimes they end up cycling back through again, or they may get out of treatment and there's no safety net for them at the other end. And then either they come back through involuntary commitment or their condition escalates to a point where they might be charged with a crime, and then they go through the criminal or the forensic side.
I see.
Yeah.
So some critics want to make involuntary commitment easier to access, but there are also critics that want to see it used less frequently. So I'm wondering, what are their concerns? Yeah.
So for I'll start with those who want to see it used less frequently. So kind of underlying this whole conversation and throughout the story, there's this looming question of civil liberties. And so when we think about involuntary commitment, it's forced treatment, and it's not meant to punish, but it is putting somebody in an institution where they don't want to be. And that can include medication, that can include, just taking away of their rights. And so the big question is this, so everybody agrees that it's not working. But, the question tends to be, should we be relying on this as much as we are? And critics, including many patients themselves or a lot of public defenders, patient advocates, will say no. And their reasoning is that it is not always successful. It's often not successful the first time. It's not always in the patient's best interest.
Is there a certain percentage of success?
So there is a stat in the story. It's kind of hard to look at that, kind of make a sweeping statement about it. But of the patients that went through the system in 2024, 20% had gone through the previous year. It's often not successful the first time. And so those who are critical of the system and feel that it violates civil liberties have said that they would like to see more what's called upstream services. So things that intervene before someone gets to the point where they need this level and this severity of treatment. And that can include crisis stabilization centers, community navigators, or people who kind of check in with patients throughout the week, or, just checking in to make sure they're able to meet their own basic needs and kind of connecting them to resources. And there's a lot of validity to that. It is concerning when you see that people who go through the system have to go through it again, or, they end up in a different but not much better situation. So that's kind of from the side of people who are critical of this system and want to see it used less. For those who want to see it made easier, the concern tends to be that, there are people who are clearly struggling and are unlikely to seek treatment on their own. I think the argument is that when this system is used, it should be viable.
Okay. So the idea of reforming the Involuntary Treatment Act isn't new. And there are, in fact, multiple reforms that are on the books already Tell me a little bit about those reforms.
Yeah, so in the article, I focus on 3 laws, all passed in the last decade or so, that attempt to reform or kind of smooth out various wrinkles in the system. And so without going into the weeds too much, the first one would sort of lower the threshold or lower the bar for getting someone into treatment by looking at someone's behavior. It would take a more objective look at that. Somebody who might have a baseline of behavior that is not very healthy or safe, not a good standard of care for themselves. The law that was passed in 2020 would take a more objective look at that and see, is this person's behavior, even if it is their baseline, is it unsafe for them? Mm-hmm. And based on that, it would be easier to get that person into treatment.
Okay.
That law has never been used because of a provision that was written into the law at the last minute, so we don't know how it works. And then the second piece that we look at is something called assisted outpatient treatment, which is something that could, in theory, alleviate the bed shortage. That is a program that would allow patients to receive treatment in a non-hospital setting, whether that's at home or in a less restrictive facility than a behavioral health hospital. So that law was passed in 2015, and it would have allowed counties to make the decision of whether they want to start this program. Only Pierce County is using that right now. King County and Snohomish have programs in the works, I think. And the reason appears to be that many counties either don't have the resources or the inclination. So that's the second one. And then the third one is something called Ricky's Law. And that's a law that would allow patients who have substance use disorder to be committed under the Involuntary Treatment Act. And so while that has been passed and it is used, according to state data, it's been used increasingly over the last few years. It's still not utilized to the full extent. And again, we kind of come back to these issues of resources and coordination. There are not that many beds for people with substance use disorder. Mm-hmm. And then it also comes down to making a decision about whether this person should be evaluated or should be committed. And that can kind of break down at various points. So when a person comes into the hospital with a substance use disorder, the hospital would have to call those designated crisis responders to come and evaluate them. They can't make the decision on their own. And they may not do that for various reasons.
Especially if time it lapses, that I can see that being quite a challenge. If somebody comes in 5 hours later.
Yeah, and so to that point, if a DCR is called, they may come in a few hours later and the person has stabilized. And so at that point, when the DCR assesses them, they may look fine. And so the DCR may say, okay, I don't think this person needs to be detained. And so there are a lot of points along that system where it can break down.
So the state is now trying a new approach to involuntary treatment reform, and they're talked about a task force. So I'm wondering if you can tell me a little bit about that.
Yeah, I would say it's not necessarily a new approach, but it is something that various entities are coming together and trying to see if they can identify some of the problems and identify some solutions. So there is a task force which is put together by the King County Prosecutor's Office. But there's a lot of people involved from all over the state: public defenders, prosecutors, law enforcement, public health officials. And I know I'm missing others. But so this task force has been going on for several months now, and they are doing what's called a listening tour. So they're going to different regions throughout the state. They're spending time in these places and holding just listening sessions with people from the community who interact with this system, whether it's people with lived experience, family members, healthcare workers, and just asking them what's working about the system and what's not. And their goal is to come back with recommendations for the 2026 legislative session.
So lastly, before we go, I do want to talk a little bit about possible solutions to this. So what does Washington need to make the involuntary commitment aspect of the mental health care system work for people?
So a big part of it is money. We've talked So we've talked a lot about the resources part. Enough beds, enough staff, and that's challenging. Several of the lawmakers that I've talked to who are quoted in the story say point blank, that's the issue: money.
Right, money.
And so I don't know what that's going to look like in the next year or two, but funding more beds and staffing them, making sure that they can stay open and be used once they're built, is crucial. And then I think the other piece of it is just getting everybody on the same page. And that's something that the folks that are running the task force have brought up, is that there's so many different entities and agencies involved in this system. It's, it spans the medical system and the legal system, and those two systems are often at odds. And so, getting everybody in the same room and on the same page, I think, is at least a good first step to understand what's not working. There may still be friction, but I think that I don't have the answers to that, but, I think that is a good starting point.
Seattle Times mental health reporter Jayati Ramakrishnan, thank you so much for being here today, and thank you for all your work.
My pleasure.
Today's episode was produced by Brooklyn Jamerson Flowers. It was edited by Caroline Chamberlain Gomez. Our production team also includes Vaughn Jones, Andy Hurst, Paige Browning, and Patricia Murphy. Greg Kramer does our theme music. Seattle Now and KUOW Public Radio are members of the NPR network. I'm Zeki Hamid. Be kind to each other, and we'll see you soon.